So we're really pleased to invite Dr. Thomas Hadjistavropolous to speak on a topic that we sometimes don't always attend to, folks living with pain that might be older in nature and other considerations. So Dr. Thomas holds the research chair in aging and health and is professor of clinical psychology, University of Regina, with a primary focus on pain and dementia. His work has emphasized development, validation of observational pain assessment approaches, widely cited clinical consensus guidelines, knowledge translation, resources for patients, and web-based training for clinicians, and pain self-management strategies, including biopsychosocial model development, policy studies, and advanced technologies aimed to facilitate pain assessment in older adults. He has many numerous publications, close to 250 peer-reviewed articles and book chapters, as well as 7 books. He is editor-in-chief of Ethics and Behavior. So I'm pleased to welcome Thomas virtually. Thank you.
So I don't know if you can see me or hear me. So I'm assuming you can. Sorry I couldn't be there. I cannot see the room. I guess that's my punishment for not being there. It's not common for me to have this many commitments out of town in any given month as I do this month, October. I have 5 different meetings in Ontario this month, so that's why I couldn't be there. And as it turns out, a friend of mine is in Calgary just now, and had I accepted, I would have had dinner with them. And so twice the punishment: 1, I can't see you; 2, no dinner. I'm going to talk about pain and dementia, and we are starting a few minutes late, so I will try to stay on time, but if I'm late by a few minutes, it's not because I didn't plan, but because we're starting a bit late. This is the expected disclosure. I have no pertinent financial interest to disclose. But I will talk about the Paxlock scales for assessing pain and dementia. I'm one of the developers of these scales, but I have no financial interest in them. This is a general outline of the presentation. Pain is undertreated in people who have dementia. If you have dementia in a long-term care environment, you are far less likely to receive analgesic medication than an individual who doesn't have dementia in the same facility when they're both suffering from the same types of pain conditions. I'll talk about the importance of using standardized scales when working with people with dementia. I'm going to talk about the Paxlock scales and recent advances in computer vision for automatizing the pain assessment in people who may not be able to speak for themselves because of severe cognitive impairment. I will make practical recommendations for pain assessment in this population, and I will present an implementation protocol that you may or may not want to implement if you're in a long-term care facility. I hope you'd want to, but maybe you're mad at me for not being there. Anyhow, are people with dementia less likely to be treated? And by the way, I have no idea if you're laughing or if you're rolling your eyes when I say this thing. So I'm just shooting in the dark here. But are people with dementia less likely to be treated for pain than people without dementia? I think I already answered that, so we're not going to spend any more time on that question. Do dementia and old age reduce clinically significant suffering? There was actually some literature 20, 30 years ago suggesting that people with dementia may be undersensitive to pain, may be less likely to suffer from pain. There's actually no evidence to support this. There's no evidence to support the idea that there's any reduction in clinically relevant suffering from pain. There are some studies with somewhat inconsistent results that show that dementia may sometimes affect sensitivity in the detection of minute differences in pain stimuli presented in the lab, but there's no evidence of any clinically relevant change. In fact, people with dementia, on average, tend to be more expressive of their pain than people without dementia. likely because of a more limited understanding of the situation leading to pain, which might increase their anxiety and fear, which becomes then part of the expression of pain. In fact, there is a very clear relationship between severity of dementia and behavioral disturbance, challenging behaviors. The blue line is people with severe dementia. The yellow line is people with mild dementia. But in both groups, there is a relationship between increased pain and frequency of challenging behavior. That relationship is far more dramatic in people who have severe dementia. Oh, and of course, also pain can lead to delirium, which can complicate its detection and its assessment. So when delirium occurs, it's important that pain be reassessed after the temporary symptoms of delirium clear up. So behavioral disturbance due to pain is frequently misattributed. It's misattributed to psychiatric causes that can lead to frequent, possibly inappropriate use of psychotropic medication and underutilization of analgesics in this population. So there is research that has clearly shown that use of psychotropic medication in this frail elderly population hastens death quite dramatically. And of course, that can be due to things like strokes or falls, that kind of thing. But when we see the appearance of behavioral disturbance in dementia, we should at least consider the possibility that this may be due to pain. I recommend that when pain is assessed in dementia, scales be used. Sometimes, or most often, pain assessment in moderate to severe dementia is based on subjective judgments of healthcare providers who may document that the patient appears to be in pain. But without the use of scales, even if something's as simple as a 0 to 10 scale, it's very difficult to communicate with other professionals as a result of a shift change, fluctuations that you might have observed in the pain experience. It allows you to monitor over time when you use scales, and it allows you to evaluate the effectiveness of interventions by systematically assessing pain before and after, for example, the administration of an analgesic medication. So what scales can you use in dementia? People with mild to moderate dementia can usually respond in a valid way to self-report scales, such as 0 to 10 scales, simple scales. So 0, no pain, 10, the worst pain possible. Most people with mild to moderate dementia can answer that question. In pain assessment, we often use the visual analog scale. Now, the visual analog scale is not a particularly good scale to use with older populations, not just people with dementia, but with older populations. We tend to see very high numbers or unusually high numbers of unscorable responses when we use a visual analog scale, especially in the horizontal as opposed to the vertical form with older adults. So I don't recommend that you use that. 0 to 10 scale is fine. And the verbal rating scale can be used as well, where the person is presented with different words and to describe their pain, and that those words correspond to a numeric rating that can easily be recorded on the chart. When you present these things vertically, for some reason, it's you're more likely to get valid responses than when you present them horizontally, possibly because many people believe vertical is more like a thermometer and people can relate to a thermometer a traditional thermometer more than they can relate to something horizontal. I don't know why, but people respond better to that. So when you use scales with this population, I have way too many animations on these things. Oh, this is another one. You used to be able to get those things for free in conferences. Now you can't get anything for free in conference for reasons that are known to all of you. But that used to be a plastic glide distributed by the makers of Tylenol, which I don't know. They used to be McNeil Pharma. I think they're still called McNeil Pharma. I don't know. But anyhow, that was a plastic glide, front and back. The person would glide the thing to indicate how much pain they feel, and then the clinician would record the numeric rating corresponding to where the glide went on the back of the scale. So when you use any kind of scale like that with older adults who have dementia, even if it's mild to moderate dementia, it's important for the clinician to do some checks to ensure that the patient has actually understood the scale. Most patients can do them, but there is no guarantee that you'll get a valid response. So if I were to show this to a patient, I might ask them a question along the lines. And by the way, this is an evidence-based series of questions. I might ask them a question. So if you had the most pain possible, where would you put the glide? And then you want the patient to show this end. And if you had no pain, where would you put the glide? And so on. So you ask them questions like that to ensure that the scale is comprehended. As a basic rule of thumb, and I think most people in the room would be familiar with the mini mental status examination, but as a basic rule of thumb, we found that patients with scores of 18 or higher on the MMSC can typically self-report pain. Patients with MMSE scores of 13 or lower have considerable difficulties with pain self-report. They're far less likely to be able to self-report it. So, of course, there is no test that will tell you for sure who can self-report pain and who can't. And for that reason, we recommend that you solicit self-report from all patients, regardless of level of cognitive impairment, because some patients with lower MMSE scores might be able to provide a rating that is valid. So as a brief summary of the self-report scales, always attempt self-report. You can use verbal rating scales. You can use numeric rating scales. You can use the colored analog scale. That's the one with the glide that I just showed you. Avoid horizontal analog scales. And these self-report scales are suitable for a large portion of patients with mild to moderate dementia. But what do you do with those who cannot self-report? And there are various tools that have been developed. Modesty prevents me from mentioning that our tool, the PACSLEC 2, is the latest version, is one of the best. So this is kind of what it looks like. Essentially, it's a checklist that staff can use. And it takes under 5 minutes to complete. And I think I have in subsequent slides some guidelines. Yes, I do. Yeah, some guidelines of how to best complete it. But we have demonstrated that not only can nursing staff and frontline health providers can complete this scale, but we have also demonstrated that lay people can complete that scale in a valid way. So if you're working, if you're a primary care provider, for example, and you're working with a dementia patient who has pain and lives at home, you could work with their family member to collect these ratings of pain over time. But it's important that you provide some instruction to the family member as to how to do that and use some of the guidelines that we will discuss today. There have been numerous investigations of the PACSLEC scales. By the way, PACSLEC stands for, do I have that up there? Yeah, Pain Assessment Checklist for Seniors with Limited Ability to Communicate. If I was naming it today, I would probably give it a different name, but I kind of like the sound of PACSLEC. but there's been numerous evaluations of the PACS-like scales, the version 1 and the version 2. So the PACS-like scales have been translated in at least 12 languages, actually more. But because I'm not very organized with these things, I don't really keep track. And I know it's more than 12, but I haven't really counted. So I say 12 just to be on the safe side. But it's more than 12. I don't know exactly how many languages. So, and it has been validated in several of those languages, although not in all of those translated languages. The PACS-like has been evaluated very favorably in literature reviews, and it's one of the most recommended tools by guideline groups, including guideline groups with which I was never involved. There have been very few comparisons in clinical settings where the various available scales for dementia have been used, and with the same population to be compared. And there was a study by Zuakalen in 2006 where they looked at the first version of the PACS-like, and they found that all of these tools that I have listed there, these three tools, the PACS-like, the Pain Hadjistavropolous, are among the most widely used tools. They were all found to be valid, but the nurses said that they found the PACS-like to be the most useful. They clearly rated it as the most useful. And as I say, nurses are always right. The PACS-like, in a series of studies, we have shown that the PACS-like has been able to discriminate painful from non-painful states better than all other tools, and that it has excellent potential for applications with patients who present with delirium, because in the latest version, the PACS-like 2, we eliminated a lot of the items that overlap with delirium. So we minimize those items, and that's why I'm saying that the PACS-like 2 scale may be good to use with delirium, just because it minimizes overlap of symptoms between pain and delirium. At the same time, I still recommend that if you're assessing somebody during a state of delirium, you reassess for pain after the transient state has passed. I'm going to tell you a study of what happens when you use a scale like the PACS-like on a regular basis in, let's say, in a long-term care environment. So we did a couple of studies, but this particular study, we had an experimental group of nurses who agreed to assess pain using the PACS-like with all the patients that were under their care. And we had a control group of nurses who did not use the PACS-like, but completed an irrelevant control tool. For instance, did the patient today watch television? And of course, the reason we did that was because if we were to show benefit from use of the PACS-like and we didn't have a control group, somebody might say, well, the reason you found benefit is because the nurses are paying attention to the patient when they're filling out the PACS-like. So that's why we have the control group. They're also paying attention to the patient, but they're not looking specifically for pain symptoms. So here's what we found. One of the things that we found was that the average PRN medication scores, we use the MQS, Medical Quantification Index for pain scales, for those familiar with that, but the average PRN medication scores during the period of the study, which was 200 days, and that's why I would say that nurses are saints for agreeing to do this for such a long period. For us, they did it 3 times a week with each of their patients. So we saw an increase in PRNs in the experimental group, which is the blue line, that's the PACS-like group, and we saw a simultaneous drop in PRN use medication in the control group, quite interestingly, possibly suggesting that maybe the staff is giving up on these patients when pain is not assessed regularly. One of the most interesting findings that came from this study was that we also studied levels of work stress and burnout in the nursing staff. And we did that because we felt that maybe the PACS-like adds workload. So let's see what happens to nurse burnout and stress. And actually what we found was the exact opposite. Oops, what happened? Oh, I'm sorry. Before burnout. forget the burnout for a second. These are the average pain scores over time in the Paxlovid group. So we saw a significant drop in pain scores from just over 6 to just over 4, which I think it's quite a notable difference. So that's the Paxlovid group. This stuff up here, that didn't change. That's just the scores on the irrelevant checklist that nurses filled out in the control group. So we did see that drop in pain in the Paxlovid group, and we also saw a simultaneous increase in PRNs. And that's not to say that more medication is necessarily better. I'm not saying that at all. Polypharmacy is a problem in long-term care, but when the right medication is underutilized, then which we know they are in this population, the analgesics, then we felt that this increase that we saw was likely beneficial for the patients, although any medication regimen, of course, for the frail elderly population should be evaluated using the Beers criteria that evaluate the safety of medications on older adults. Now, back to the burnout. The nurses are filling these things out. And what we found actually that nurse burnout and stress scores in the experimental group, given the Paxlovid, reduced over time, whereas those in the control group did not. We did not study why this happened, but anecdotally, nurses told us that they had more confidence in their clinical decisions when they used the Paxlovid, and we know that lack of clarity about the decision making for a health professional can increase stress, uncertainty, but also it's very possible that when you manage pain better, you see a reduction in challenging behaviors on the part of the patients, which improves the quality of the care environment. I don't know if you know this, but long-term care nursing staff, frontline nursing staff in long-term care, are the occupational group the most likely to be assaulted on the job, more likely to be assaulted on the job than police officers. So this drop in burnout was positive. I'm trying to convince nurses, if there are some nurses in the group, which I hope they are, to use the regular pain assessment. And this study supports the idea that there's nothing more relaxing than sitting under a palm tree, holding a pina colada with one hand and filling out the Paxlovid with the other hand. Oh, okay. So then we did another study, similar study, where in this particular study that I'm about to talk about, we took two pretty much identical, well, nothing is identical, but very similar long-term care homes. One was using the Paxlovid on a regular basis, and the other one was not. And we did that study because in the study I just discussed, we found that change in PRN medications. We did not find a change in regularly prescribed medications, which meant that the nursing staff either did not inform the physicians of the findings of the pain assessments, or they informed the physicians and the physicians felt that they didn't need to do anything different. And in fact, this latter idea that healthcare providers in primary care will often ignore the results of pain assessments is supported by at least two studies, one of our own that we conducted, where we showed that pain assessment information was disregarded, and there is another similar study in the United States that found the same result. But regardless, we felt, how can we do better? How can we get primary care providers, physicians, working with these long-term care patients? Because in Saskatchewan, we don't have a lot of things. And one of the things we don't have is we don't have physicians in long-term care. Unlike the Netherlands, where it's amazing to be in a long-term care facility there, but that's a different topic. So how can we get physicians more involved, more engaged, so that they can take into account the pain assessment results? So in this different study, we took these identical homes. And in one experimental condition, the condition where we gave the Paxlovid on a regular basis, we had the research physician in our team. And the intervention, in addition to doing the assessment, was that the research physician in our team would call their colleague to discuss the pain assessment results when we found something significant. And that simple intervention of having one physician call their colleague to tell them about the pain assessment results turned out to be very effective. The physicians responded, they were open to it much better than they responded to the patient when the patient requested intervention. I'm not going into the methodological details of that study, but versus somebody sending them like an assessment result report. And as a result of that physician involvement, in that study, we showed reductions in unnecessary polypharmacy with effective pain assessments, specifically in the use of benzodiazepines. So these are MQS scores specific for benzodiazepine use. Look at the baseline that the control group and the Paxlovid group are exactly the same, virtually identical in their use of benzodiazepines. Post-intervention, several months later, we saw a drop in benzodiazepine use in the Paxlovid group where pain is assessed, our physician is calling their physicians, versus the control group that has actually doubled. They've doubled the use of benzodiazepines. So pain assessment doesn't seem to only improve care in terms of better analgesic use, better environment with staff feeling less stressed, but also seems to have an impact on reducing psychotropic psychiatric medication use. So how to best assess pain in people with dementia? Obviously, you have to take into account patient history, physical examination results. You cannot assess pain in a vacuum. We recommend the use of self-report and observational approaches. Use both if possible. Older adults with mild to moderate dementia, to summarize, can typically use this simple self-report scales, and then use the good standardized nonverbal assessment scales such as the Paxlovid. Now, this is very important. Pain assessment during a movement task is far more likely to identify an underlying pain problem than when the patient is at rest. We have shown, and others as well, that if nurses observe a patient over the course of the shift and note pain behaviors they might observe, then they can successfully identify pain. But if it's a brief assessment, a movement-based task is better, and there's different pain tasks that can be used. Different movement tasks, depending on the level of frailty of the patient, but often during dressing, like if there is a shoulder problem and people have to put shirts on and that kind of thing, that's where you might see pain. But when you do that, use a movement-based task. And of course, if you're assessing pain over time and you're comparing results over time, you got to always use the same task. You cannot compare a result based during a shift, the entire shift, to a result based on, well, putting a sweater on. Examine whether an analgesic trial results in a reduction of behavioral indicators of pain, because sometimes we're not sure, are these behaviors due to pain or not? Well, a simple analgesic trial, such as a Tylenol or whatever is appropriate for that patient, before and after assessment could increase your confidence as to whether what we saw was due to pain or not. Remember that when people have chronic pain, it's not just about pain intensity, but chronic pain can go hand in hand with lowered mood. So you want to assess the impact of the pain on the general well-being of the patient and address that, especially in frail older adults, I would suggest with behavioral intervention rather than with more medication. solicit assistance of knowledgeable informants. People say, what is the cutoff score? We want to know the cutoff score. I say, you don't want to know the cutoff score. There is no good cutoff score for any of these scales. Some of these scales for pain assessment in dementia recommend the cutoff score. I argue that that's a bad practice. It's a bad practice because, one, dementia is not a single condition. Dementia is a very diverse group of brain conditions, each of which has a different impact on the brain and behavior. For instance, somebody with a frontal dementia will be far more likely to be expressive of their pain as compared to someone who has dementia primarily affecting the posterior of the brain. So you can't use the same cutoff score for these two people. You can't use the same cutoff score for a patient who is ambulatory versus one who's not. Because if you can't walk, then you can't limp. Well, then you couldn't possibly get the highest possible score because you're not limping. That's one of the behaviors we're assessing. So you can't use a cutoff score. It's just not appropriate. Duration of observation will also affect the score. The longer you observe, the more you'll see. So what do? We recommend that you use an individualized approach where you monitor pain consistently for every patient over time. And then you're looking for fluctuations from the regular pattern of scores. How do I operationalize this? Well, I guess I would say the more you assess, the merrier. But considering practical and resource constraints, we would recommend a minimum of once a week pain assessments that take 5 minutes. These types of screening assessments, a minimum of once a week pain assessments for people who have dementia and cannot tell you about their pain. And of course, more often, if pain is suspected, that's the point I made earlier. You have to assess pain consistently over consistent circumstances if you're comparing scores over time. And you may still be able to miss pain occurrences with these tools. They're not definitive indicators of pain, but this is what it looks like. This is an actual patient. Actually, that might be a fake one. That is a fake one. That's not the real patient, but actual patients look very much like this one, where you assess over time. That is the box like too. So you assess over time, and you can see the scores are not that different. And then suddenly you see a spike there. That's an indication that something is going on. In this case, we had an abscess tooth, which resulted in increased pain. And once that abscess tooth was treated initially with antibiotics, then you saw that there was a reduction in the pain. And then following the extractions, you saw the expected increase you would see. But that's how you can assess pain. Comorbidities can complicate the experience, such as delirium and depression. There's my implementation protocol. We recommend minimum of once a week to assess pain, assess all patients on admission if we're talking about a long-term care home. Treatment plans should be implemented within 24 hours at the latest after pain is identified. Reassess after you implemented the treatment plan after 24 hours to see if things are working. And we recommend that facilities use pain assessment results as part of their quality improvement indicators. Are you effective in addressing pain? So normally I don't show this picture anymore, but we're now in Alberta. So this is, I thought I found a picture of my colleague Alex Michailidis initially on the internet, but it was actually Mike Riley, your former quarterback in Edmonton. But then anyway, I found the correct picture of Alex. And Alex is a biomedical engineer at the University of Toronto that has completely changed my thinking about how to best assess pain in dementia, given the current resource constraints. As a result of my interactions with Alex, I have come to believe this, that over the course of our lifetime, over the course of our lifetime, the best solutions to the problems of Alzheimer's disease and other dementias will not come from the medical sciences, but will come from technology development. I can elaborate this if we have questions. We don't have much time left. I'm treating this as I'm having another 12 minutes, given how when we started. So I could give you numerous examples. I'll just mention self-driving vehicles. Imagine what those can do for a person with sensory impairments, with cognitive impairments, in terms of their ability to stay at their homes and to be independent, perhaps with a caregiver approving trips, if appropriate, with a smart device. So technology can really change lives. And we have developed computer vision technologies that we're testing now to assess pain in dementia as people go about their daily routines. There are some things that we have done with technology development. We have developed an online training program for rural long-term care staff in best practices in pain assessment that is available. We have an app of the Paxlock 2, and what the app can do is it monitors pain over time, so that you don't have to go to the chart, you don't have to control scores, you fill up the thing, and it'll graph the scores over time, and you can see where your patient is at. Then we did the computer vision, and then of course we use the internet for knowledge mobilization campaigns. We looked at different quality indicators for our various interventions. This is after we implemented the training program and regular use of the Paxlock in rural long-term care facilities in Saskatchewan, to see what difference this online training makes when combined with an implementation protocol. These are 7 rural facilities in Saskatchewan. This is how many people were being assessed for pain in these facilities for a minimum of once a week. 0%, 0%, 0%. And look what happens when the staff are trained and implementation protocols are implemented. 0% became 98% in this facility. Now 98% of patients are assessed regularly, 35%, 0%. That's a significant increase, a major increase, from 11% to 100%. This is the app. So let me just tell you, and that's the last main thing I will discuss today. Let me tell you about this computer vision technologies that we're testing now. The idea is that there'll be cameras in the long-term care facility that capture pain expressions and pain behaviors as people go about their daily routines. How do we address privacy? We address privacy well, I think, because nothing is recorded. Nothing is displayed. So this is all processed internally, and if pain behaviors are detected, there is a notification that goes to the nursing station to check a patient. That's the ultimate goal. Right now, we have it 1 patient, 1 camera. That's what we're testing. But ultimately, we'll develop this as an ambient system. And if we can do that, that system creates the tantalizing possibility of being able to continually monitor pain behaviors in any given patient, which is something that no human assessor could ever do. So to develop this system, we video recorded patients with and without dementia from 3 angles of observations. We coded these facial expressions and some body behaviors of these patients frame by frame. That meant 1,060,000 frames were coded for these patients. And we used that coding to train the vision algorithm. I work with computer vision experts. I'll introduce you to one. These are the heroes who completed the coding of the 1,060,000 frames. 2 of them, Odell Tan and Brooke Hoffman, are now physicians doing the residency in Ontario. And Erin Brown here is a doctoral psychologist. This is my collaborator from Toronto Rehab. He is a software engineer. Let me just show you this clip of how this works. What you'll see here is so there is a mesh that the system uses to detect the face, to detect the eyes and the nose. That was easier said than done, because one challenge we faced was we couldn't possibly, we thought we'd just fit the mesh. You know how in Snapchat, you fit a mesh and then you can put little glasses and ears and stuff. Well, as it turned out, a lot of the long-term care patients were in a bed, which meant they had the head tilted from the pillow. So that messed up the mesh fitting completely. And it took Babak, my colleague, and his doctoral trainees and postdocs 1 year to fit the mesh, given the tilted head. But anyway, it was done. So this is the mesh fitting. And what you'll see here is, once the video starts, you'll see the level of pain detection. This line is the binary no pain, pain. So when the line is crossed, you'll see pain behavior here, and you'll have a detection. So look carefully what happens to this woman's face in relation to the line. So, oops, yeah, there we go. So here she is, no pain, no pain. This is the line. And once this crosses, that's when the system detects pain. So far we have no pain. Still no pain. No pain, no pain, no pain. Ah, pain. There you go. Line crossed. So that's the idea of how it works. We're in the last couple of slides, so we're almost done here. But this is the accuracy of the system for different cutoffs that we use. You know, this particular one has a true positive rate in detecting pain of 85%. It's still not good enough for clinical use. So we're working to improve it, but it's getting there. It's getting there with 85% good detection. So that's what we're working on now. These are my trainees in the lab who currently are conducting this work. These are my funding sources. And because I'm a clinical scientist, my last slide has to be a pie chart. You can have a clinical science talk without a pie chart. So there's your pie chart. And that's my presentation. Thank you very much. So now I don't know what happens, but I'm just gonna
Thomas, I don't know if you can hear me. Can you hear me? It's Christelle.
I can hear you.
Oh, wonderful. Thank you so much for joining us virtually. We know you have a very busy schedule, so we do have time for about 10 minutes of question and answer. So if you're able to stay with us for a bit longer.
Yeah.
Go ahead, Flo.
Okay. Thanks for your talk, your presentation. That was really awesome. Very interested in your technology development and how well this facial recognition works with non-Caucasians, first of all. And secondly, I've worked with patients who are incredibly stoic, and their facial, you cannot tell from their face that they're in pain. I'm thinking of an 88-year-old who, when I asked her to rate her chronic pelvic pain, said it was a 10 out of 10. But you had no idea looking at her face or by her function. So how does the technology overcome those that have a, I guess, predisposition to being very stoic and hardly show any emotion in their face? Thank you.
So thanks for the questions. These are excellent questions. With respect to the former, how well it works for non-Caucasian faces, we actually could not recruit enough non-Caucasian faces, although we tried. What we do know is that facial recognition does not work as well for non-Caucasian faces. And of course, the darker the skin is, the poorer the detection. So that's a real problem for this technology. So we definitely need to do a lot more work to improve the technology to work equally for everyone, because currently I don't believe it would work as well for non-Caucasian faces. And I think that's a major problem with the technology. With respect to the second question, what you do with a stoic individual, well, the system can only be as good as a human assessor, because its ability to detect pain is based on inputs provided by a human, based on what a human assessor would do. So if a human assessor cannot assess, or cannot identify or detect the pain behavior, the system will not be able to detect it either. Now, generally speaking, people will be more expressive, as I mentioned, during a movement-based task. So if you want to assess a person's pain, if it is physically safe for them, according to, say, a physical therapist that they have a shoulder pain, if it's physically safe for them to move their arms, then you do that, and that might show more behavior. So, but the system is always going to be as limited as a human assessor is.
Thanks, Dr. Hadjistavropolous. Ooh, I needed to practice that.
You don't have to.
I just wondered, with people that are losing their language with primary progressive aphasia, or as they're losing, are there measures that are more aphasia friendly? I realize behaviors and facial expressions are fantastic, but just wanted your perspective.
Well, I mean, for any nonverbal patient, I would say this measures would work. I don't know for any specialized tools. There may be some. I don't know of any that are specifically developed for people who have who are aphasic but have their remaining faculties intact. I will mention this though. We just completed a study. We're in the process of submitting it for publication, and there's a proliferation of different tools like the PACS, like developed for people with dementia. And then there is tools developed for people who have intellectual disabilities and they're younger. And then there is a tool that was developed specifically for people who have orofacial pain. So we operate under the assumption that we need different tools for different populations. So in this study, we tested tools developed for people with dementia, a whole bunch of them, versus tools developed for younger adults with intellectual disabilities versus this orofacial pain tool on a dementia sample with no specific type of pain. And we found that all of those tools actually were valid, raising some question as to whether do we indeed need different tools for different populations who present with cognitive impairment. So I don't have a good answer to your question, but the best I can say is that I think these tools would work for a patient with aphasia just as well. We have used the tools in at least one study for people who don't have cognitive impairment. So if somebody has aphasia but no other impairment, I think these tools would still work. But they can also, of course, you can use like cards where they can point, like the glide that I mentioned. I don't know, it might work for some patients, but.
I have a question, actually. I really appreciated strategies to utilize different tools for numerical scaling, like saying less horizontal, more vertical. So I'm curious if you have any examples for languaging and speaking with persons who are suffering from pain and also live with dementia, just languaging and talking to them about their pain. Do you have any suggestions for that as well?
I feel that I'm not doing a good job answering the questions. No, I don't. I mean, I think it's important to take an individualized approach depending on the level of comprehension with the patient. Patients can typically understand simple statements such as, does it hurt? Where does it hurt? How much does it hurt? So there is actually studies that use those simple statements, and they show that they result in answers. But specific language to use besides those types of things that are intuitive, I'm not sure I have any other ideas.
No, sounds really good. Thank you. Any other questions? All right, we do have one more from Stu.
Just in terms of the social component of pain and automated assessment of pain, do you think that will provide more opportunity for social engagement if you're monitoring them through like just addressing the pain component and addressing the other social components?
Yeah,
Go
that's
on.
a very interesting empirical question. On the one hand, one can make the argument that we're dehumanizing the process. We're taking away that component, notwithstanding the fact that pain is not assessed otherwise. But somebody might say, well, maybe it's better to put our efforts in getting a human to do it. And that's probably true. I think it's better to get a human to do it. But if we can't, then what happens? So the other argument that can be made is that if the automated system results in better pain care and people in their quality of life improves, challenging behaviors go down, then maybe there'll be more socializing happening. So I think it's an empirical question, and I think that some might argue that it takes away socialization, but others might argue that it may at the end result in better socialization and people have less pain. But that would be a very interesting study.
Hearing no other questions, no further questions, we again want to express our gratitude for you joining us virtually. We wish you a wonderful weekend in Regina to come, and perhaps our paths will cross again, and maybe you can come visit us in Alberta.
Thank you very much for having me.
Thank you so much.
Bye-bye.